Good evening, everyone. I am Dr. Richa Kothari. I work in Narayana Rudula. I would like to present a new thing which we've been doing in the last year. So there are a couple of cases where we've done some CT-guided transcatheter interventions. So one of them is in superior sinus venosus ASD. So as we can see, this is a superior sinus venosus type of ASD. You can see that the SVC is draining into both LA and RA, and we can see there's associated PAPVC with some of the right upper lobe pulmonary veins draining into the RA. So usually the treatment is surgical, where the surgeon goes and operates and closes the ASD. But in the last few years, there have been, in India at least, I think Dr. Shiv Kumar from MMM has been doing stenting of superior sinus venosus ASD to close these ASDs. So we've been using covered stents to close these ASDs where patients don't need to undergo surgery. So at our place in the past 1 year, we've done around 15 cases with excellent results. So I felt it's a good thing to share with everyone, because with such good results, it'll probably take up more and more and more and more people will start doing it. So what the radiologist needs to know in such cases, so essentially they need to know a lot of information from us, because based on the CT, they'll decide whether the patient is eligible for percutaneous stent placement and covered stent placement of superior sinus venosus ASD to treat it. So what they want to know from us is this distal SVC diameter before the PAPVC joins in. They want to know the diameter at the RA-SVC junction. They want to know the length of the SVC, which is distal to the innominate vein and till the inferior margin of the ASD, because that will determine the length of their stent. So why do they want to know all these measurements? So then they're going to go ahead and balloon this area to check the drainage pattern. So this diameter, the distal SVC diameter, is very important for them to decide which size balloon to use, because the SVC is not that expandable. So they only can use a sort, they need to know which size balloon to use. So that will depend on the diameter. So these measurements we need to give them. And so this is that same patient who's then undergone the stenting, and see these are the excellent results where you can see that the ASD, so this is the ASD which has been completely closed, as we can see, and the PAPVC, as we can see, is now draining into the LA, because the stent placement is in such a way that the ASD gets closed but the PAPVC drains directly into the LA. So just one stent placement and all your problems get solved. So this is another case, how it differs from, so similar as you can see, uh, the superior sinus venosus ASD with the PAPVC, with this, and this is the superior sinus venosus ASD. How is this case different? There's an additional ASD. So this is another thing you need to tell them. So in this case, they have again done the stenting, as we can see, and they've completely closed the superior sinus venosus ASD, and they've also done a device closure of the additional secondum ASD. So again, complete percutaneous treatment. This is the third case. Again, superior sinus venosus ASD with PAPVC. However, here you can see there's a separate drainage of the segmental vein into the, other than the lobar vein, into the SVC. So what happens in such cases is, when they put the stent, this will get jailed, in the sense it will get occluded, and that will not drain. So we need to tell them when we are reporting this, that one of your segmental branches will be occluded and will not be draining. So that single or segmental branch being jailed is acceptable, because even if the patient had gone for surgery, the surgeon would not have touched this. He would also just have repaired this PAPVC and ASD. So one segmental branch is acceptable, but you need to mention it in your report. So as you can see, this is the stent, this is the closure of the ASD with the stent, and this is that branch which got jailed. As you can see, it can't drain. However, here you can see the lobar branch is very nicely draining into the LA directly. Another thing we need to tell them is dual SVCs. Because if there are dual SVCs, the diameter is narrower than usually than if it's a single SVC. So they need to use a smaller size balloon Otherwise, it will be a failure of a procedure. So few points we need to tell them: measurements at certain levels, distal SVC, SVC RA junction, distance from anomaly vein to inferior margin of ASD, mention if there's a dual SVC or additional ASD, and look at the drainage of pulmonary venous pattern and report it in detail. Another procedure I would like to talk about is, so port shunt is a procedure where there's anastomosis between LPA and descending aorta. It is basically done to decompress the RV in severe pulmonary hypertension. So it's a palliative procedure and it's usually done surgically. However, we can do it percutaneously, and again a lot of planning will depend on our CT. So we have done one such procedure, so I'll just very quickly take you through what it is. So what we need to do is, first, very simple, in the axial plane itself we go to the plane where the MPA bifurcation is. You can see the LPA and the descending aorta close to it. So we go to that plane where descending aorta is closest to the LPA. At that plane, we see how much is the contact. So it's around 16 by 16 millimeter contact, correct? So then at that 16 by 16, we have to very minutely examine. So in that 16 by 16 at T6 level, there is some small bronchial artery between the aorta and the LPA. So essentially the shunt is going to be between these two. So there can't be anything between that. So this level is out. I would tell, don't go at top level of T6. There are small bronchial arteries. Let's see my next option. T5 mid level, again it's close, but there is calcification. So if they want to go at this level, I would say aim anteriorly. This is all information you need to give them. So best is T5 at the low level, where they are very close to each other, nothing is in the way. So I say, okay, T5 low level is the best. Go there. Then at that level, we need to give more details. Gap between the LPA and descending aorta. So in this case, it's 1.5 millimeter. Then next, we need to tell them the angle which they will use during catheterization, during angiography. So in this case, the angle I got for RO, right anterior oblique, is 21.5. So how did I get it? Straightforward, just a vertical line. Okay, and this is the diameters. I've measured the diameters of aorta and LPA in one plane. In that plane, perpendicular to that, you draw a line. So the angle between this and this dotted line and this 21 is your angle for projection. And after that, we need to acquire, so this was all in axial planes. Now you need to go and play in sagittal obliques and get this view. Here, what have I done? I've simply made, instead of aorta being round, we've made LPA round so that aorta is parallel. So now LPA is round, so this is sagittal oblique, LPA round, aorta with a parallel appearance. And again, we measure the diameters of both. And once you measure the diameter, the angle between that diameter and the parallel axis of aorta is the angle at which they will puncture. So they just need to get that angle and they'll puncture in the cath lab and they will get direct access to the port shunt like this. This is an article if you want to read up in more detail about how we did these measurements. And so this is with what we've been doing in the past 1 year, especially the superior sinus venosus ASD has really good results. So probably more and more people will take it up. So as a radiologist, play with 3D MPR, speak to them, speak to interventionists, know what they want and discuss. Thank you.
Nice cases, Richa. Just so you took all gated scan.
So our cardiac protocol is one gated, one non-gated.
Okay, so both.
So yeah, I would like to introduce the next speaker.
Yeah. Just to inform, Dr. Ron Jacob is also there online, and so Dr. Tarun and Dr. Ron also.
Thank you, Richa, for very interesting cases. May I ask you, in terms of cost of the interventional procedures and the durability of the percutaneous procedures in India versus just doing open surgery?
So durability, I don't know because we've just started this. This is just our experience in the past 1 year. We do not have long-term follow-up, but immediate results have been really good. And the cost is the cost of the stent plus the procedure cost.
Because I believe the surgical procedures are cheaper in India compared to stents, unless the cost of these these must be covered stents. I
These are
presume.
covered stents, right?
Their cost has come down or been capped by the government.
No. It does end up slightly more expensive than this, but we found a lot of patients willing to undergo because that surgery versus stent
Sure, yeah.
is a
But very clever way of managing these anomalies. Thank you.
thank you, sir. We just I accumulated. No, we've done superior sinus venosus ASD stenting. We've done around 12, 13 cases in the last 7, 8 months. I think our team will. No, no. There's so much work. So, every age, mostly adults. Yeah. So next next interesting case will be presented by Dr. Noori. Now we have two congenital cases, Dr. Noori and Dr. Mega, back to back, and our president will take over now.
Good afternoon, all. I present my interesting case for 3 minutes. We'll open for discussion with Dr. Sandeep, Dr. Tarun sir, and everyone else, and Dr. Rajesh and Mega also. Ron, yeah. So this is a 60-year-old female presented with chest pain, dyspnea on exertion for 6 years, 2D echo, dilated right heart chambers, severe pulmonary artery hypertension, large OSASD, 60 years. Large OSASD, normal biventricular function. These are the images, axial images, and axial images and oblique axials. You can see that there's a almost aneurysmally dilated main pulmonary artery, right pulmonary artery, and you can also see an OSASD here. OSASD here. So she had presented with chest pain too, in addition to SOB, 60 years old. So probably they were neglecting her. Now, when we did a CT angio, we could make out that the aneurysmally dilated main pulmonary artery was compressing the left main and causing severe stenosis, which was a cause for her chest pain, was thought of, and they did these are the pictures of playing around with VRT, just to show that there's huge dilated main pulmonary artery compressing over the left main, and they went ahead and did a stenting. She doesn't have chest pain anymore. So one take-home message from here is that ASDs and all these primary pulmonary hypertension, severe PAH, if MPA is dilated more than 4 centimeters, or the angle of takeoff of LMCA, which Dr. Sandeep will let us know in his paper. I am quoting his paper also here. He has written a paper on this. So remember that chest pain and LMCA compression can occur other than atherosclerosis in these compression syndromes. And primary pulmonary hypertension is the commonest cause, followed by AST, followed by sinus of valsalva aneurysm not ruptured. These are the causes in order causing the extrinsic compression of left main other than the atherosclerosis, which causes intrinsic narrowing. Similar case, one more, 23-year-old female, ASD, severe PH, again presented with DOE and chest pain. Similar again, 53 millimeters is the main pulmonary artery. You can see the OSASD, you can see the severe compression of LMCA, stenosis, and I don't have the post-treatment images with me, but she also has been stented. So these again just some kind of pictures which are more appealing. So extrinsic compression of coronaries, 7 to 29% of patients with pulmonary hypertension may report typical characteristics of angina pain. So just you can read out, you can go and look at the article which now MPA is more than 40 millimeters, you suspect pain. These are the causes. Dr. Sandeep, please, I want your comments on this. Your article. I also want comments from Rajesh and all pediatric. One was 60, one was 24.
Great case. Thank you for sharing the article as well as two interesting cases. Um, I think when we do, we have a large referral center for patients who are adults and congenital heart disease. And because of that population having increased incidence of enlarged pulmonary arteries, when they come to us with diagnosis of chest pain, we do multi-phase coronary CT on them, and we look at left main. The compression can also be of the LAD, so it's important to look at both these vessels. It's not only the angle, but also we report the cross-sectional area of the vessel. And when you have multiple phases in the cardiac cycle, we look at the phase where the cross-sectional area is minimum, and then report that in our report. With regards to the management, I have seen a couple of things being done in my center. If the patient is very old, they have somewhat borderline symptoms, a cardiologist likes to stress them first to see if there is an ongoing ischemia. And if there is an ischemia, then they have severe stenosis elsewhere, then they are offered CABG. If it's a single vessel disease and they are symptomatic, then I've seen other interventional cardiologists are phenomenal in their expertise, also seeing them placing a stent in the left hand. But it's technically very challenging.
Is not done because continued extrinsic compression would again lead to stent fracture or restenosis. Similarly, we do for the thoracic outlet. I am an interventional radiologist, so in thoracic outlet syndrome, we do not put stents. A bypass graft is a preferable technology. So yes, it would make sense if it is a 75, 80-year-old doesn't want to undergo CABG, you put a stent. But how long will this stent survive this much extrinsic compression? Because that thing is still there.
Absolutely. You are only treating what you're seeing on images. You are not taking away the potential etiology that is causing the compression. Exactly. So I think the balance is the stent is chosen as an option only when it cannot do for procedures. I think, and then these patients, when they come to us, they are already optimized for their pulmonary hypertension. Yeah.
Can you give her a mic, please?
So the bridging outlook, I think bridging is something that is extremely common. Very common, to the extent that many centers in the United States don't even report in their parables. It is important, however, to note bridging when somebody is planning to place a cabbage graft, because the surgeon will have a hard time trying to find the site for touchdown. So when you are doing a pre-operative assessment for cabbage, it is really important to mention that. Another thing is that people generally mention bridging in context of other cardiomyopathies. Like bridging is extremely common in patients who have hepatic cardiomyopathy. So it is important to know that. And some people say that we should also mention whether the bridge is superficial or deep in the myocardium, which we do. Yeah. So.
Yeah, agree to all that, but the point is that is anybody doing stress testing on these bridge patients?
No, we are not.
We're not. Okay.
No.
Okay. But I think that's because the person probably did not know there's a bridging. You see, on an angio, they never know. So must have had a stent.
But the stents don't work in the bridge, myocardial bridging. They fail generally, as Priya said earlier. They don't work. Yeah.
Sandeep. I have one question to Sandeep. Sandeep, can I ask you? You keep the mic with you. I just want one clarification. Sorry, I'm pushing you. Sure. One clarification. When we evaluate for percutaneous pulmonary valve implantation and RVOT dilated coronary compression, so when do you measure the distance between the RVOT and the coronary, diastole or systole or in both, and what are the criteria? That's also a compression.
So a loaded question. So when we do RVOT assessment for transcatheter pulmonic valve placement, we provide systolic as well as diastolic images, and the measurements that we include is both systole and diastole of RVOT, pulmonic annulus, main PA, right PA, and left PA. With regards to the coronary relation, it is pertinent because every interventional cardiologist is going to start by placing a balloon at that site. Particularly if you have anomalous coronary which has a pre-pulmonic course, then it is likely to get compressed. And so the incidence, and this is, I'm quoting the Melody registry, which is what we have in the literature. The incidence of coronary compression in relation to TPVR placement is very low. I want to say around 1 to 2%.
But measurement, they ask for measurement distance between the RVOT and the coronary. It should be in diastole or systole or
Both.
what?
We provide both.
And the minimum distance or?
Minimum distance.
Thank you. Thank you.
Aortic diameters will be maximum in end systole. So your compression is maximum in end systole. So we should mention in end systole there is a significant stenosis. But all said and done, the coronary perfusion happens in diastolic phase. So diastole, if it opens up, so then there is nothing to worry. So it's better to mention both. But the reason is the maximum compression will be in the end systole, but you are interested in the diastolic perfusion, coronary perfusion, which is going to happen. So this
Thank
is
you,
how
ma'am.
it is. No, no. Yes. What we are looking for is a fixed compression, which has now become, for a long-standing compression, which has become fibrotic and thick, and it's not, yes.
Ron, any comment here? Ron, you're with us?
But I think you really have to call it out, even if it's a dynamic compression. I think it should definitely be on paper, because even if it opens
Any
in
comment, Ron?
diastole, I would still call it out.
We cannot hear.
Ron, you're mute. Ron, you're mute. Yeah, now it's okay.
He's not.
He cannot hear you? You cannot hear us.
I think he's not on mute, but we can't hear him. Even.
Okay. Fine. We can go to the next page. We will check it out. Yeah.
Yes, so I'll present an unusual case. We'll go step by step. So, 1 month, 6 days old female child brought with incidental discovery of murmur and feeding difficulties. Chest X-ray showed right-sided aortic arch. Echo revealed suspicion of vascular ring because there was a right aortic arch and an aberrant left subclavian artery. So, referred for CT-PA. And CT actually showed two separate PDAs on same side. Both were arising from the aberrant subclavian artery, left subclavian artery, and going to MPA bifurcation, and one towards LPA. So I'll show you the case. Not visible. I've changed. Here is next. this. Sorry. Okay, so as we go up, what we can see is, we can see an ASD here, dilated left atrium and left ventricle, changes of pulmonary arterial hypertension. So this is the right aortic arch, and this is the aberrant left subclavian artery, and there are two vascular channels that are coming from the aberrant left subclavian artery. This is the superior one, okay, and this is the inferior one. I'll show the images in MPR also. So can you see, this is the superior channel and this is the inferior channel, both coming from the aberrant left subclavian artery and both going towards the MPA. I'll show you the reconstructed images also, annotated and reconstructed images. So this were the VSD, PH, the pulmonary arteries. So what they've labeled it as left aortic arch, actually it is the superior PDA and this is the inferior PDA. Two channels connecting the left aortic arch to the MPA bifurcation. These are the VRT images that beautifully show both the PDAs, the superior one, the inferior one. This is the aortic arch, this is the comerals diverticulum. These are both the PDAs that are connecting to the MPA. So then echocardiography was done again. And they showed that this is the descending thoracic aorta, these is the aberrant subclavian artery, and when they rotated, they could also show both the PDAs. So this is how that image, still image, it was descending thoracic aorta, the superior and the inferior PDA, and this is the aberrant left subclavian artery. So there was the discussion. We know this is a complete vascular ring. Now what could be the embryological basis of two separate PDAs on same side? Either it could be dorsal collateral artery, or it could be the persistent fifth arch derivative, which we call the great mimicker. Those were the two discussions that were discussed because it doesn't fit into definition of any of the existing vascular anomalies. So again, for fifth aortic arch, we can consider that fourth aortic arch derivative is subclavian artery, and then we can consider this as a connection between fourth and sixth aortic arch because it is connecting with the pulmonary artery. But aberrant subclavian artery has a different embryological origin because it is due to the involution of fourth arch and persistence of the seventh intersegmental artery. So now again it is pulmonary is derived from sixth and this is seventh. And I have two articles. See, one article is the great pretender in clinical practice, where it is called that persistent fifth aortic arch is an extra pericardial structure, but it should arise from the ascending aorta proximal to the origin of the brachiocephalic trunk. Okay, so by definition, our channel doesn't fit into this definition, and it should terminate in the dorsal aorta or the pulmonary arteries. Depending on that, there is a classification whether it is systemic to systemic persistent fifth aortic arch, systemic to pulmonary fifth aortic arch, depending upon where the distal end is connected. So our distal end was connecting with the pulmonary artery, but proximal end was not connecting proximal to the brachiocephalic trunk. So that is why this is the classification of the persistent fifth aortic arch. So we could not fit into the definition of persistent fifth aortic arch, and maybe a dorsal collateral artery, though there was no cause for the two separate same side PDAs to happen in this patient. So actually management wise, they divided both the PDAs and the patient is doing fine. I'll show you the post-op images also. So the post-op scan was also performed. I'll just minimize this. So these are the post-op volume rendered images, and we can see both the PDAs are divided, the compression is relieved, the patient is doing fine. So this was, yeah. So any inputs?
We are not going to see it again in our lifetime. So,
So,
Yeah, very simple. I think very, very interesting, very rare congenital case. My very basic elementary question is how do you do a CT scan on a child of that age?
sedate means we are at an institute, so we have anesthetist available. We do 2 non-gated scans, both
Non-gated.
non-gated scans
Under GA.
under GA. Yes,
Right. So quick
run.
fast
Yes.
run.
Both non-gated, and we make sure in the second run to include the upper abdomen, because we have been able to diagnose a lot in that also.
I would like to
Thank
share
you.
one thing here actually, because sir spoke about sedation. Last 1.5 years, we've not been sedating babies at all. We just wrap, and we've been able to get beautiful images.
What scanner are you?
256.
So it's important to know what scanner you're using.
G, no flash. One gated, one non-gated.
Okay.
Just make the baby quiet. The point is the speed is such beautiful that a small
Fasting. The children are fasting. Just before they go on the table, they are fed, and immediately they go off to sleep. So they are tightly wrapped and put on the table. But this high pitch sequences will also, they are also very, very helpful. So it's just 3-second scan. So by the time the child
Anyway, so
cries,
small, ma'am. The z-axis itself is so small, so it's very quick. We have. Sorry, we use the injector. We get beautiful. By the time they wake up, the scan is done, probably.
Why do you do 2 non-gated?
We don't do 2 non-gated, ma'am. We do 1 gated, 1 non-gated.
No, Megha, why do you do 2 non-gated?
See, we find enough diagnostic quality images even in the non-gated first scan. Even the proximal coronary arteries are nicely seen. Rather than going for that gated, increasing the scan time, increasing whatever radiation we are giving, we have found it useful. We have not missed the.
Do you have a dual source scanner or
No.
single source?
One single source. 128 slice.
Okay, thank you.
Okay, moving on to MR, we have Dr. Ritu presenting to us about apical HCM.
Okay, so yeah, so this is going to be a very simple thing. This is a 40 years old male. Can you please shut off the slideshow? It keeps on going to the next slide, even before I finish this slide. I can click and then. So this is a 40 years old male who presented with non-specific chest pain to the cardiology OPD, and he had visited twice in the last 2 years with similar complaints, and the ECG showed there were changes of cardiac hypertrophy, but the echo was normal. And his blood pressure was also normal. There was no other clinical complaints. So He was just put on conservative management, was sent home. Then there was no other history of past history, personal history, family history of cardiac issues. Now this time when he came, third time in last 2 years, then echo showed concentric LV hypertrophy. So now then he was sent for cardiac MRI to see the kind of cardiac hypertrophy. And if you can, these are the short axis and four chamber cine images, and we see there is some degree of hypertrophy involving the basal and mid anterior anterior septum. There's also apical hypertrophy most marked in the distal inferior segment. And if you look at this, the four chamber images, you can see there is a small crypt, and in systole there is mid to distal systolic cavity obliteration, and it gives a classical ace of spades on a two-chamber view. And on a post-contrast images, we could see these on PSIR some patchy mid-mycal enhancement in a pattern which is consistent with hypertrophic cardiomyopathy, apical hypertrophic cardiomyopathy. So the diagnosis of apical hypertrophy was made. But you can see, as in this case, there is only a little bit of apical ballooning, which we can see on both two-chamber cine as well as the short axis and the PSIR. Now, the degree of apical ballooning varies. This can be minimal, as we see in this case, or it can be extensive, leading to a degree of classic aneurysm formation with a ischemic pattern scar. So, this degree, the measure of degree of apical cavity obliteration is important. How do you take that? You take the length of the apical cavity obliteration and divide it by the end systolic length, taking from the base of the mitral leaflets to the LV apex. And if the ratio is more than 5, then there is increased incidence of atrial fibrillation, stroke, heart failure, and cardiovascular death. And therefore, the degree of obliteration rather than the thickness, the apical wall thickness, is actually of prognostic importance. So, cardiac hypertrophy affects 1 in 500 people, and it has multiple genotypic phenotypic variations. It's unexplained left ventricular hypertrophy more than 15 or more than 13 in some series in the absence of abnormal loading conditions. However, apical hypertrophy is diagnosed when there is predominantly LV apex. And this is important because it has increased prevalence in athletes. It's low prevalence in sarcomeric gene mutations, which is the most common in HCM. It has characteristic structural features including apical scar and aneurysm formation, and it has a different risk profile with more thromboembolic events, atrial fibrillation, and stroke. And therefore, the diagnosis of apical HCM is important, and CMR is the best modality to see that. Now we have 3 different types of apical HCM. Is pure, when there is more than 15 mm thickness. In some studies, we use a 13 mm cutoff, and the hypertrophy is only in the apical segments. And then we have a mixed pattern where we have apical plus septal involvement, but more of apical involvement. And then we have a relative type when the thickness is less than 15, means it has not reached there, but there are some findings such as there is a loss of usually seen apical myocardial tapering, systolic apical cavity obliteration, and the wall thickness is increased but is not reached the 15 mm cutoff. So initially, relative apical HCM was thought to be benign, but now we have data that shows that it is associated with increased LA size, aneurysm formation, myocardial scarring, and therefore it actually may represent early disease that with time may progress to overt apical ACM. So apical ACM traditionally has been considered to be non-obstructive because there is no LVOT obstruction and no SAM. And all patients, both early and late, have apical ischemia. So these are the 2 papers which is the basis of my talk, and this recently came out in Circulation, and that was in JACC. So in this article, they described that every patient of apical HCM, early or late, had apical ischemia. And this is because this contraction, the systolic contraction had a compressive effect on the microvasculature, coupled with impaired diastolic relaxation, reduced the normal coronary flow, and therefore there was apical ischemia. And because of that, there was replacement fibrosis, and the LG pattern was in apical and subendocardial. And majority of patients with LV apical aneurysm had associated mid-ventricular obstruction, and papillary muscle hypertrophy kinds of act as a plug when they occupy the crowded mid-LV. And the importance is that if further observation confirms this hypothesis, then that the mid-LV obstruction is contributing to aneurysm, then it is a potential therapeutic target to prevent, limit, and delay the supply-demand ischemia and subsequent aneurysm formation, which is the poor prognostic cause in this group of patients. Now, there is a relationship between the size of the aneurysm and the subvalvular apparatus. So, the length of the subvalvular apparatus is the distance from the tip of the mitral valve, mitral leaflets to the base of the anterolateral papillary muscle. So, when you have a long subvalvular apparatus, in this case we have, then the aneurysm is small. And when you have a short subvalvular apparatus, this is a different case. Then the amount of ballooning or the aneurysm is large. So CMR has distinct advantages in diagnosing apical SCM because it visualizes the apex and the apical pathology such as a scar and aneurysm much better than echocardiography. It determines the extended apical phenotypic features including the milder variants of apical SCM. It measures accurately the aneurysm size and especially of size more than 2 cm or equal to 2 cm associated with increased risks of sudden cardiac death. And it also measures the end diastolic thickness and scar percentage, which are another risk factor in sudden cardiac death. Thank you.
Dr. Rizuk, can I ask a question? Yeah. Thanks for the interesting case. What was the thickness of the myocardium in the apical third on the end diastolic phase in this case?
In what segment, sir?
The thickness of the myocardium in the apical third.
In the apical inferior, it was 1.6.
Sorry?
1.6 centimeter
1.6,
in the apical inferior. But the apical septum anterior and the lateral wall was 1.2 around.
Okay. So what were your criteria in this patient to make a diagnosis of apical HCM?
So the diagnosis was suggested because of multiple things. One, we had at least in one segment the size was larger than 15. The thickness was larger. End diastolic thickness was more than 15. Then on cine images we had that classical apical ballooning, the mid and the distal systolic obliteration with apical ballooning. We had the scar pattern, and we had that pap muscle which kind of obliterated the cavity. Given everything and the patient symptoms, we think it is one of those milder variants of apical HCM.
So would you call this case a pure apical HCM, or you think it's a mixed type? Because there is septal hypertrophy also, there is mid LV hypertrophy also in this case.
So pure apical would be one when we have a apical hypertrophy in all the segments. In this one, it was actually kind of patchy. In the basal and mid segments, it was not.
So you're not saying it's a pure apical?
I don't have a case as of now. I have seen, but
it's a mixed pattern.
Yes, somewhere I've seen these cases. I don't have it right.
But you showed that spade pattern, didn't you?
Yes.
Was that your case? In this case only?
This one was my case. The second was mine. I don't have a complete right now. I don't have it. That's what
I have just two comments to make. One thing is, in India we also have EMF. For the residents to remember that a very close differential diagnosis of pure apical HCM also keep EMF in mind. So if you have rounded apices more frequently seen on right side and on also sometimes in 1/3 of the patient bilaterally, then EMF also should be kept in mind. Only difference would be it will not open up in diastolic phase. Apical HCM, it will become the thickness will change between systole and diastole, whereas in your EMF, besides your LG and thrombus and so many other things, in the cine also, you will have a fixed sort of thickness. Second thing is also the apical thickness is slightly more than the basal thickness. So it does make sense to have a ratio of basal and diastolic thickness and apical in mind. So if it is more than 1.2 or some people say 1.3, then we consider as apical hypertrophy. So some little bit of hypertrophy is present in apex if you compare basal versus basal.
Other point I want to mention.
So the mid cavity was on the anterior and the interoceptum. All together, when we put it on cine, it was causing this mid-systolic and the apical obliteration.
Yeah, but the only thing is that when you were talking about the dilatation, the apical aneurysms. The apical aneurysm classically happen when there's a mid-cavity concentric hypertrophy or a, even if it's eccentric. But effectively, you have to have a mid-cavity, clogging off for that dilatation, unless and until you end up with a burnt out stage of hypertrophy.
Agree.
The other thing also is very important for the residents is to understand the phenotypic and the genotypic hypertrophy. And the third point I wanted to make was that when you were talking about microcirculation and the spasm, it's not only that, it's also the fact you've got hypertrophy and the amount of volume of coronaries that is going and getting subtended to those vessels is much lesser, to that mass of myocardium.
Yeah.
So that's why they're talking about FFR and evaluating the LV mass versus the flow within the coronaries in order to understand whether there is a sufficient amount. Especially that happens even in the athletes. That's where the problem comes. When you have LV hypertrophy versus the amount of blood subtended through the coronaries.
The case was actually intended for beginners and starters, and to emphasize that CMR has a very important role in apical HCM, and you might not have a full degree of apical ballooning even with a cavity obliteration, because the morphology of the papillary muscle and the subvalvular apparatus might be different in different patients. So we can have a spectrum.
Yeah, I just had a comment to make because your question could not have a better timing, because yesterday night only I was going through a paper published yesterday in JACC Imaging by a team from UCL, James Moon's group, that rather than that, indexed myocardial wall thickness at the apex probably would have a more diagnostic accuracy for predicting apical HCM than a fixed cutoff of 1.5, because we can miss more cases if we use a fixed cutoff. It should be body surface area dependent. They proposed 5.2 to 5.6 probably as the upper limit of normal for thickness, myocardial wall thickness at the apex, the unindexed equivalent being 11 millimeter. So probably the threshold itself is slightly higher, but of course I haven't read the paper, but
Yeah, good point.
It's an important point.
Yeah, I think Roy also said, Rob, your comment on this particular thing, which she has read just one day prior, new article.
Can you hear me?
Yes, sir.
Oh, sorry. Okay, great. Yeah, the one is the Moon paper that just literally got published, I think arbitrary numbers, cutoffs, 1.5 and 1.6 sometimes can take us down the wrong road, because you can have people with apical HCM with smaller or more subtle degrees of hypertrophy. The appearance of the ventricle is really important. Looking for the gradient. Normally, in a normal morphological ventricle, the apex usually thins out. And if you see that there's a discrepancy between the basal segments and the apical segments, then you should look at it a little closer and not be dogmatic about arbitrary values. And the second thing I want to make is apical HCM is the one type of HCM where the genetic testing, the yield is quite low. So that's where cardiovascular imaging really helps, and having a big threshold or a strong threshold to suspect the disease, especially since, if you have an apical aneurysm, that's an independent risk factor for sudden cardiac death, independent of the other factors. So I just want to make those 2 points.
Thank you, sir. While the next speaker readies her talk, so I would just like to kind of add for people who are starting off reporting CMR that usually when we teach or when you learn HCM, the thought is patchy mid-myocardial enhancement. So apical HCM is one case where you will very likely see subendocardial enhancement in the apex, which is due to HCM, not due to coronary artery disease. So keep that in mind when you're looking at apical HCM, subendocardial enhancement you may see. So moving on to Tosha. Tosha is going to talk to us about mass mimics.
Okay. So good evening, everybody. So if you are espionage thrillers, you would know that a mole is a person who is within an organization but is working for somebody outside it. So this is the story of one such mole in the heart. Ours was a 28-year-old female patient. She presented with sudden onset acute left-sided chest pain since one day, and at local hospital, the ECG revealed dynamic STT changes in lead 1 and AVL. Troponins were mildly high and there was a rising trend. But 2D echo incidentally showed good LV function and a suspicious mass-like structure attached to the tricuspid wall leaflet along the interventricular septum. But since we are seeing at a acute coronary syndrome picture, she was further advised coronary angiography and then she came to our institute. So on admission, troponin 1 levels were markedly elevated and patient was treated on the lines of acute coronary syndrome with antiplatelets and statins, and then after she underwent coronary angiography. So these are the images. LAD and LCX in the left-sided circulation was absolutely normal. You can see RCA is good calibered, patent, clean, and then it divides into PDA and PLV. So PDA, just after the division, is mildly ectatic, and then there's a sac-like structure of contrast that seems to be attached to the PDA with a stalk, this stalk. And if we see the PLV, then there is this hazy filling defect in proximal to mid PLV. Now, this defect is not associated with any abrupt stenosis or tapering, and the distal PLV has a good runoff. Maybe it is filled retrogradely. So the report that came out was that it's a single vessel coronary artery disease. The RCA is dominant. There is an aneurysm of the posterior descending artery, and hazy filling defect in PLV could be either spontaneous coronary artery dissection or it could be a thrombus. So now if we remember that the 2D echo had revealed some suspicious mass-like structure, right? So then we proceeded with 2D echo in our institute. And this is the subcostal view. I hope you can appreciate that there is this rounded echogenic structure which is in the basal inferior RV wall, RV cavity, and it's quite close to the tricuspid annulus. So these are the static images. This is the rounded structure, and on it's not that vascular, it's not vascular at all. And if you can appreciate, there are some, it's predominantly echogenic, and there's some cystic lucencies within the lesion. So again, good LV ejection fraction, walls were normal, and our cardiologist thought it was some hypertrophied muscle bundle, basically a pseudomass. He was thinking on the lines of a pseudomass. So then we did an MRI, and these above two images are black blood images. You can see that the lesion, it pops up quite well, and it is quite iso-intense to the adjacent myocardium. The third image is the stir image. Now, stir image, we were not able to conclusively determine whether there is edema in the LV walls or not, but yeah, the lesion appeared slightly brighter. And this is the short axis cine views, where you can see that the lesion is centrally hyperintense and it has a hypointense wall. So this is cine images. You can see the lesion very well popping out, just inferior to the septal leaflet of the tricuspid valve. And 2D scene images, sorry for the image quality, but you can see that the basal inferior and mid inferior walls are slightly hypokinetic, and just as we come across the inferior RV insertion point, we see the lesion. Okay. Sorry? Yeah, so just let me get through it. Okay. So this then we did an RV inlet outlet view, and we can it's just to depict that how beautifully we could picturize that lesion on RV inlet outlet view. The valve is clearly quite appreciable, and the lesion is just subtricuspid. Okay. So then these are the first pass. No, ma'am, just let me get through it. So these are the first pass images. We said that, see that the lesion is not enhancing in the RV phase, but just before the myocardial phase, it starts to enhance, and it remains persistently enhanced in the LV phase, in the myocardial phase. Okay. So these are the delayed enhancement images. What do we see here? We see that there is scarring. Not scarring exactly, there is not much of thinning, but yeah, there is LG more than 50% transmural in the basal inferior and mid inferior walls. Okay. So static images, RV inlet outlet view, this is the lesion, and first pass arterial phase, just see the contrast within the coronary artery. At the same time, this lesion has developed contrast enhancement persisting in myocardial phase with washout on early and delayed enhancement phase, and a LGE in the basal inferior wall. So, sorry? So just let me finish. So by now at large we knew what we were dealing with. I thought somebody of you also might come up, because we directly did limited coronary angiography for that patient. And see this image. This is RCA. This is the dilated PDA, early branching, giving rise to coronary aneurysm that we saw on cath angio images. It is burrowing through the myocardium through a narrow neck and projecting in the cavity, and the rest of the PDA is also seen. So it was indeed outside the organization, but it seemed to be a part of it. So, okay. No, unfortunately, and very regretfully, the patient refused for any further imaging. She was not happy with the way we were conducting her examinations. I don't know why, but so this is just the report for your reference, just repetition of what I said earlier. So final diagnosis was interventricular posterior descending artery aneurysm and associated infarct in basal inferior wall of left ventricle with more than 50% transmurality. She underwent percutaneous coil embolization with followed up 2D echo after 2 weeks. So this is the post-coiling appearance, and on echo you can see those coils also. So we have majority of the times come across coronary aneurysms in literature as giant ones, and that too they project within the right atrium more often, but ours was a small one. It projected completely within the ventricle, and the location was also a little bit atypical. It was in the PDA. So CT versus MRI, we would have loved to perform CT angiography for this patient because we wanted also to see. Yes, ma'am. As per the MRI, whatever we could see, nothing at all. Yeah, 20-year-old female, and so we wanted to rule out any further, but she went to have a second opinion somewhere, and they directly did coiling. I didn't want to disclose this, but yeah, this is what happened. So yeah, so we could have evaluated CT in CT angiography. We could have evaluated for any wall calcification, thrombus, stenosis, atherosclerosis. If we were talking about SCAD, that Sandeep sir has already written a paper about, we could have also seen perivascular fat stranding or an intramural hematoma. And CT angiography outperforms MRI in detection of small fusiform and distally located aneurysms. But nevertheless, because we were thinking it was a mass, we did MRI for tissue characteristics, and we could pick up myocardial infarction. And cine MRI for cardiac motion, including that of aneurysm. It would have, if it would have been a larger, we would have also been able to appreciate any turbulence of the flow within the aneurysm. So I don't have any take-home message for you. I just have take-home questions. What could be the etiology? See, majority of the aneurysms are atherosclerotic, but this patient had no cardiovascular risk factors. In all probability, it was congenital. And congenital aneurysms have a low propensity to thromboembolize, but this one did. And age of infarct, she complained of similar such episodes in the past, but I think though we couldn't find any edema on stir, this could have been of the recent origin, that PLV, it matched even with the PLV territory, so it was, I think, of the recent etiology. And any intraluminal thrombosis, this question could have been very well answered if we did a CT. And cause of filling defect in posterolateral ventricular branch, it has to be thrombus because there is an embolic source. So it has to be thrombus. Besides, if you saw the post-coiling CT angiography, that defect in PLV had cleared already. Now SCAD doesn't clear on its own like that so quickly. So it has to be thrombus in all cases. But if it was a thrombus, then how did it reach into the RCA and then into the PLV? So that question is still bugging us. Thank you so much.
I think most likely the thrombus formed in the aneurysm itself, and then it dislodged and went into the posterolateral branch.
So it had to travel retrogradely first into the PDA.
No, not retrogradely. It went in a way retrogradely, but so because the flow in the coronary artery is directly from RCA approximately distally, so that led into the posterolateral branch. Most likely.
So it had
most likely. But what is very interesting here is the extension of aneurysm into the cavity of the right ventricle. Has anyone seen a case like this?
Actually, did anyone guess that it was an aneurysm? When because if you just look at the MR, it's like it's an intracardiac mass, till you do the
Maybe because the inferior wall was scarred, so the burrowing into the myocardium was possible. That was the problem. Yeah.
So that the aneurysm is the mole. We think that it is working within the heart, but is actually working outside it. It's from the coronary. So So we have a hole in our, so many laymen saying a hole in the heart, a hole in the heart. So I have a mole in the heart. Sorry? Yes. Okay. See, I had to introduce such twist in a relatively simple case. Thank you.
Yeah,
thing that was seen.
So
They didn't have a flow on the 2D echo. I'm sorry.
No, ma'am, it didn't have a flow. That
Surprisingly,
is what was
because
also that is also a reason why it could have been thrombosed. But we
thrombosed
couldn't
later after doing the CT, after the
doing
coronary angio.
Before, because there was an embolus, it must be thrombosed. Some thrombosis might have been there, but then again, on MRI, we couldn't appreciate that thrombus. That is why we thought that if we had done CT, we could have exactly quantified how much thrombosis is there. Because on echo, it appeared echogenic. Otherwise, it should have appeared cystic with flow. Yeah, so we knew, ma'am. Oh, sorry? We saw, okay. No, but ma'am, we were not sure. We were not sure that this could have been that aneurysm so much, I mean, it's protruding completely in the ventricular cavity. Yeah. No, ma'am, she never had any scans before. She had just. Okay. So then it would have been a pseudoaneurysm if you say like that, right? But she had no history of any intervention. And it is eccentric and secular, but then congenital aneurysms can also be secular. Yes, sir. I have got references, but most of them they are about giant aneurysms in the right atrium. I have. That is.
Thank you, Tosha.
Thank you.
Shubhajit will continue with the saga of masses and mass mimics.
Hi, very good evening to everyone. So I'll present a case of cardiac myxoma with unusual CNS symptoms findings. So basically, we had a 41-year-old male who presented with the CNS symptoms like the history of giddiness, headache, past recurrent stroke-like symptoms, never been hospitalized for any reason, and was not on any kind of medications. So as usually, we did an initial CT brain, which revealed minimal acute subarachnoid hemorrhage in the right frontal region and some areas of chronic lacunar infarcts. The other basic lab and baseline investigations were pretty normal. They did not reveal any disease, and we move on to do a CT, as implied, we move on to do a CT angiography of the neck and brain, which was also normal. So as a routine procedure, as the patient was hospitalized, they did an echo, and the echo is very clear. Like after all these sessions, everyone can appreciate that it's a large sessile mass arising from the interatrial septum, which is going into the LV cavity through the mitral annulus during the cardiac motion. But it has some friable margins, as you can see along the wall. So we did an CMR for this patient. The CMR also revealed a pretty similar findings. It was similar kind of an intra-atrial septal sessile mass, highly mobile and protruding into the LV through the cardiac motion through the mitral annulus, the fourth chamber view, and also the third chamber view, having the similar kind of appearance. So the cardiac myxoma was made not from MR but also directly from the echo. So till now what we have a case of cardiac myxoma, the 41-year-old who presented with the CNS symptoms, who presented with a hemorrhagic stroke, and was not on any medication, did not have any past history. So we know that the ischemic stroke is quite common in cases of cardiac myxoma. And so we were divided among what to do next. So should we do for further investigation, or should we level it as a small vessel stroke maybe, since the CT angiography was normal? But there was one team who said that let us do that, and we have an aggressive neurointervention team who said that maybe let us go for some additional investigation, and that's why they convinced the clinician to do a cerebral DSA. And look what we can see in this cerebral DSA. We can see that some areas of small aneurysms we can see in all the vascular territories in this cerebral DSA. Also appreciated in the static images, you can see small microaneurysms in all the vascular territories. So the patient underwent a resection for the myxoma. We encountered the patient 3 months back, so we did not have a follow-up after the operation. So the patient is still on follow-up. So the point is that actual myxomas present approximately 50% of the cardiac tumors. It is not uncommon. The embolization of the tumor materials or the thrombotic material covered with the tumor cells approximately occurs in 35 to 40% of the patient, which leads to ischemic stroke in them. So the association of the ischemic stroke and myxoma is not uncommon. In contrast, the formation of intracranial aneurysms associated with atrial myxoma are very, very rare. To best of our knowledge, we have less than 20 cases of cardiac myxoma associated with intracranial aneurysm reported in the literature. And what are the possible theories? There are few theories which can explain the evidence of intracranial aneurysm in these patients. These are basically infiltration of the cerebral vessels by the tumor cells through the vasa vasorum, leading to vascular wall damage by the tumor cells and perivascular damage and aneurysm formation. So this is the most prevalent theory that exists. There is occlusion of the vasa vasorum, the tumor damage of the tumor cells by the tumor walls, leading to aneurysm and the pseudoaneurysm formation. So intracranial aneurysms in a case of left atrial myxoma are very rare. The myxoma presenting with the CVA, if we are especially in this case where we had an hemorrhagic stroke, we should go for a more invasive or more aggressive investigation like DSA. And the point is that how does it help that even after myxoma resection, these tumors, these aneurysms, which are tumorous cells, may persist for several years, and if it is a growing aneurysm, chemotherapy or radiotherapy may be considered in these patients. So this is in briefly my case. Atrial myxoma presenting as intracranial aneurysms. Thank you. Yeah, Carney syndrome. Yeah. Yeah, that we did not have any clinical evidence of that. And usually they present with multiple myxomas. Yeah, we did a CT angio.
Did you go back to your data and see if they were there?
No, yeah, it was evaluated by us. It was evaluated by neuroradiologists. Everyone who is an expert in that field, and it was not. No, we did a CT angio. We found it was normal. Then we did a DSA.
So did you go back to the data?
Yeah, we went back. It was not same. No. Because these are very peripheral aneurysm, very small. So beyond the spatial resolution of CT. This constitutional symptoms.
Shubhajit, I would say here.
Yes, sir.
No, as you said that these microaneurysms are very rare, only 20 cases reported, and yours is 21st case possible.
No, that is what they are saying. Maybe it is more than that. So yeah. I came up with two literature. One is 20 and one is 40. I gave the 20.
So I would not say that one should do a cerebral DSA in all these cases because myxomas are common tumors. So unless there is a very good reason, like hemorrhagic stroke patient, like in this case, only then perhaps cerebral DSA must be done, but not otherwise.
Yeah, we are waiting for this patient to come back and we do the second DSA after the resection. Probably we can compare the aneurysm size and follow up.
Do you think a contrast MRI angio?
No. For the brain. It is inferior to CT.
I think that's.
Contrast only.
Do you think that would have better spatial resolution than CT angiogram, MR angiogram?
No. But he says no, not to CT. CT says he went back and he says no. I'm
Yeah.
surprised.
Yeah.
Actually, CT is supposed to be quite good.
But compared to CAT, I think.
CAT is better, no, sir.
Yeah.
No, but at times the smaller results, okay, I understand. Yeah, yeah, possible, possible. So, very good.
Okay. Thank you, Shubhajit. We come to the closing batsman of the day, Dr. Babu Peter, with a.
So, what's the score of batsman? What's the score? Anyone? No, but what was Pakistan? Kudi, where is this projector? Come on, you promised the projector to us.
No, projector is the dinner.
No, last batsman, no. Next you show it them.
For the GBM. Okay.
Dr. Babu Peter with a suspense case.
No, it's okay. Good evening, everyone. And I'll just, for a few minutes, I'll just pass through this case. It is this case that we had recently. It's not a very mysterious case or anything. This actually, we had this reference from a place called Salem, which is about around 250 kilometers from Chennai. It was referred to our institute for cardiac MR. This patient was a 45-year-old female who initially presented to the ER with chest pain, dyspnea, tachycardia, and hypotension. There was a massive pericardial effusion and an emergency echo-guided pericardiocentesis and drainage with inotropic support was done. This was followed by a subtotal pericardiectomy. And this was found to be a hydrated cyst, and you can see that there is a pericardial cystic lesion there with bilateral pleural effusion. So this was done in about 2 years back in 21. Then a post-op CT angiogram was also done, and this again showed this pericardial lesion, cystic lesion with the bilateral pleural effusion was there. So this cardiac MR was requested. Now we did it about a week back, and there was persistent pericardial pain. And we did the cardiac MR, and we saw that there was again this cystic lesion was there. It was an insinuating cystic lesion in the pericardial region and abutting the free wall of the ventricle. So again, this the cine images which showed that there was a pericardial cyst. And again, if you look carefully, within the inferior wall appears relatively thickened compared to the anterior wall, the septal and the lateral walls. So that was initially looking abnormal. And this is the black blood image that revealed that. And when we did the parametric mapping, in T1 mapping, you can see that the fluid, which is had high T1 values, and that's the inferior wall, you can see that there is significantly increased T1, about 2000, where the values here within the inferior wall. And again, in the T2 values, the values were very high, which was corresponding to the values within the pericardial fluid, which was hydrated cyst. This is the post-contrast images, which did not reveal any significant enhancement. Post-contrast LG images, you can see that cyst, which is showing an enhancement, and you can see that there is extension of the cyst intramurally, and there is a subepicardial enhancement as well as enhancement subendocardially as well. And there's just a peripheral enhancement was seen. So this is actually a case of hydrated cyst, which is post-operative and followed up. And interestingly, we found that there was an extension of the pericardial cyst into the myocardium. And usually hydrated cysts may be intramural, and left ventricular hydrated cyst classically with septations and others have been reported. And myopericardial hydrated cysts have not been reported frequently. And especially with the cardiac MR, very few reports are there demonstrating in the parametric mapping as well as and with the LG images showing these images. So actually when we found it, I was very elated actually for finding this myocardial pericardial cyst. I wanted to inform them, and we called my postgraduate, they completed, they were a resident, they were doing assistance in Salem, and we got the old reports. But this was the echo that was actually done recently that showed the cyst. And so we thought we had diagnosed recently, but in 2021 we did not have the history initially. So this was, they did aspirated pericardial, purulent pericardial fluid. It was found to be a ruptured hydrated cyst with multiple daughter cysts attached to the LV apex. RVOT and aorta pericardium was thickened, and the inflamed epicardium was adherent to the underlying myocardium. And they had actually done the pericardiocentesis and excision of the cyst. And the histopathology at the time came as hydrated cyst involving the pericardium. Although when they did the surgery, they found there was myocardial involvement as well. So that corroborated the findings, although we did not have this history initially. So we were, it was confirmatory of the myocardial extension of the cyst and intramurally. So I just wanted to show this cyst, show this to demonstrate that the myocardial extension of a pericardial cyst, which is not very common and which is not in the native T1 and T2 mapping. I have not seen a case which has been reported as well as in the enhancement, in the late gadolinium enhancement images. So usually in endemic areas, hydrated should be considered as a differential diagnosis for cystic lesions, even if the serological analysis is negative. And the developmental characteristics of the right heart hydrated cyst are quite different from the left heart. In the right side, an intracavitary and subendocardial expansion of the cyst can occur, while on the right side, and they tend to rupture, which can lead to pulmonary embolism and anaphylaxis and death. But in the left side, there is a subepicardial growth of the hydrated cyst, which is seen. And this rupture can occur into the pericardial cavity, which may lead to pericarditis, pericardial effusion, and cardiac tamponade, which was the presentation in our case. So this was a pericardial hydrated cyst with the subepicardial growth presenting as a cardiac tamponade. So the hydrated is very common in the liver and lungs, but we all know it can involve the heart. It may be asymptomatic, but it can present with just a simple precordial pain or even a life-threatening tamponade. And the common sites are the left ventricle, which may be intramural, followed by the right ventricle and pericardium. And it can also spread via the coronary circulation. So what is important to remember is that the left ventricular hydrated cyst can grow subepicardially, while the right ventricular hydrated cyst grows intracavitarily and subendocardially, which is more prone to rupture. And primary pericardial involvement of hydrated is quite rare. It may be usually secondary to intrapericardial rupture, presenting as pericarditis in effusion and cardiac tamponade. So MR is very useful to predict the exact anatomical location and the nature of the cyst and post-treatment follow-up as in our case. And I wanted to show this case to show the images findings in the late gadolinium enhancement and the parametric mapping, which has not been reported before. Thank you all.
Thank you, Dr. Babu Peter. Any comments? Any?
What did you say?
Thank you, sir. Thank you, Dr. Ron, being here, for being with us for the session. Sir, one second. We would like to felicitate the speakers for this session. Dr. Babu Peter, Priya ma'am, if you could come and felicitate, sir. Dr. Noori? Dr. Telka, sir, if you could felicitate Dr. Noori. Thank you, sir. Megha? Thank you, Dr. Megha. Dr. Ritu Agarwal. Dr. Sandeep, if I could trouble you to come felicitate her. Thank you. Dr. Tosha Desai. Yeah, yeah. Dr. Shubhajit?
Richa, you did the honors.
Uh, Dr. Elizabeth, ma'am, if you could please come on stage to receive your memento. Dr. Tarun Mittal, sir, if I could trouble you to felicitate Dr. Elizabeth.
Richa, just give me 1 second. I request all of you to stay back for GBM. After this presentation, GBM is there. Please stay back for GBM. Yeah, industry, yeah, definitely.
Yeah, the industry sponsored people, please stay back. Yeah, we want to thank you.
Dr. Elizabeth. Thank you, sir. Dr. Noori, sir, if you could felicitate Dr. Stelkar. Thank you, sir. Last round of felicitation. Dr. Vimal Raj, if you could please come on stage and felicitate our organizing secretary, Dr. Pudyavan. I think
Great applause.
Great round of applause.
Dr. Priya. Great job, Priya and Pudhivan. Great job. Ron, you are with us. Thank you, Ron, for being with us and giving that extra time to us. Is he there? He left? Thank you, Ron, again. So we can proceed to the next.
No, for industry.
Yeah.
I hope industry people are here.
Yeah, we got. Yeah, come, Krishnamurthy. A4, AI4
Yes.
medical imaging.
So
And we got.
Healthcare and AI for medical imaging. They are the platinum sponsors of the event. So Mr. Krishnamurthy is here. Bart is there. Yeah. Okay, fine. Yeah, sir.
You can go that way.
Yes.
Thank you again, sir. It is the support which you all give us, which help us to conduct such conferences where we can do multiple activities with the ethos of taking the education to the tier 2 and the tier 3 cities. Thank you again, sir. Thank you again. Robert from Neosoft. Robert has been with us for the second consecutive annual conference. Thank you, Robert. This time we gave you a very warm welcome for 2 days. Please be there. United Imaging? Anyone from United Imaging?
Pass.
Okay. Siemens? Anyone from Siemens? Philips?
Philips, yeah. Philips, come.
Philips, please come.
We are also there.
Thank you for your support, sir. Thank you. Please come. Vivere Imaging, please be on the dais. Yeah, please come, sir. Come. All three of you can come, no problem.
We thank Vivere Imaging for sponsoring gifts to all our international faculty. Thank you very much.
Come. You're most welcome. Go, please come. Hi. ACFA, please come. From Ruday, is he there? I met him outside. Okay. From Acton, Milind, be ready here. Yeah. Thank you again. Not the least, JB Chemicals, Milind, and his colleague, company, sir.
Yeah.
Milind has also supported us all year round for the educational activity for the monthly case, right? Thank you, Milind. Yeah. Thank you for the support. And friends, please also be available for the evening gala dinner, the industry guide. Please be available for it.
Yeah. So when we are telling thank you to everyone, I just want to say that all this is possible because all our executive committee members, all the team. Yeah. No, I want to call. Yeah.
Vishnu.
So basically, I want to tell what everyone has done, what they have been doing all the time. So, yeah.
All the members stand up on the bench.
I remember Vishnu's entry into the team when it was the last moment he came joined.
Abhi de देते Yeah. Yeah. So from all these years, paper and poster presentation, getting those images and getting them, segregating them, mailing them every day, selecting them. Dr. Aparna and Dr. Vishnu, please come on the stage.
Even for delegates, you have to clap. They also sat through.
This time we are giving President Appreciation Award. This is Dr. Noori's idea that we should definitely. Yeah. Yeah. I'm ready.
Thank you. Yeah.
Yes.
Not tonight.
Yeah. So this case of the month activity, which continued all throughout. This was Yashpal's idea, and he really carried it very well. So I want to invite Yashpal, Ankita, and Tosha, who manage case of the month.
Yashpal has done a wonderful supporting job to conduct to maintain the web page and also other background digital activities. Thank you. Presidential award, IDP.
Yeah. Yeah. Then this time in a year, we had four midterm meetings and one annual meeting. First time in the history of IACI. So thanks to Nilay for Nagpur, Shubhajit for Kolkata, Alpa for Wadia, Dr. Suman for Jaipur, and Dr. Pudivan. All 5 of them. Thank you.
Vimal, please come, you can hand over some.
This is such a pleasant surprise.
Dr. Suman?
No, she's not.
She's not there. And all these years, whenever there is a workshop, Richa and Omkar have been the backbone for technologist workshop, for all the workshop, they are always there. All the cases, whenever we do workshop to do the live demonstration, the entire team and Richa and Omkar, please come on the stage.
Richa? Omkar?
Yeah. The quiz, what you see, is done by Megha and Ashita. Megha and Ashita.
You asked for 1 year's time.
Yeah. Megha and Ashita. Uh, yeah. Dr. Ritu for academic webinar, she really conducted. Is she there? Dr. Ritu? Okay. And we can't forget the strength of our association, Trupti. Though she is not there physically, it is every 1 year, and I'm sure all of us, whoever, whenever there is some paperwork, some academic work, Trupti has been really the strength of the organization. But I just must admit that, yeah, yes, all the whatever is done, I mean, Parul is such a strong support. She's the treasurer and she's always there for anything. So I would request Dr. Hemant to give it to Dr. Parul. Yeah. Yes. Yes, yes, I'm calling. And I can't forget Bhavna, though she is not physically in India, she is always in the group. Her heart is still here, and I'm sure she will come back to our organization very soon. So she is always part of the team. She plans her vacation whenever we have our annual meeting. So Bhavna, please come.
Your heart, your soul, your mind, everything is there. Please come.
Yeah. Yes, yeah. And yes, yeah. But the family cannot be there with, with some godfather or some parenting father. And I really, whatever we are there from the EC committee, it is actually because of all the, the seniors have given us free hand and they've really guided us all throughout. So I think all of us require to give standing ovation to Dr. Noori, Dr. Vimal, Dr. Rajesh, Dr. Hemant, and Dr. Sanjaya, who is not there. They are the core members and they've really helped us. No amount of no envelope can do justice for that. Yeah. It is all the years what they have done all throughout that this is possible. Thank you. Thank you.
I, no, I just want to thank, again, what Priya ma'am already said. I would really want to thank the seniors for giving us this opportunity. You all have let us come so ahead, and that's why we could stand here in front of you. It's all thanks to you. And so ma'am took some of the words from my mouth, so I would like to thank her and Dr. Parul also. Thank you very much, and I hope we can live up to your expectation.
So the academic session is over here. We will now continue the GBN. Those who are members of IACI, please stay in the hall for the GBN. The rest, thank you. We'll see you in the evening and tomorrow morning.